the early 1970s, Dr. David Rosenhan, a Stanford psychologist, orchestrated one of the most famous and controversial studies in psychiatric history. Known as On Being Sane in Insane Places, Rosenhan and 7 other pseudo-patients checked themselves into different psychiatric hospitals across the United States. Each claimed to hear voices, saying words empty, hollow, and thud. All 8 were admitted. All were diagnosed with schizophrenia or bipolar disorder. But here's the twist. Once inside, they acted completely normal. Despite this, it took an average of 19 days for them to be discharged, and only one hospital ever suspected the deception. The staff interpreted everything from journaling to pacing as evidence of mental illness. The study rocked the mental health world. It forced psychiatry to confront the subjectivity of diagnosis and led to a renewed push for more consistent diagnostic criteria, which would later shape up into the DSM-3 and beyond. Rosenhan's work remains controversial, but it powerfully underscores this episode's theme. Diagnoses are not always what they seem, and in our field, clarity saves lives. Hey, welcome to Licensure Lifeline and a new year. This podcast helps people prepare for counseling licensure exams and hopefully help you thrive beyond that. I'm your host, Matt Lawson, licensed therapist, and your companion on this journey to becoming a clinician. Today kicks off the first episode of the year, and I'm going to try to do something a little different here, where I really schedule out these episodes in a way that I can kind of start each year with this format. So I'm hoping this goes well, and you're going to see a little bit more structure to what I'm doing as I go. But honestly, whether you're studying for the NCE or NCMHCE or working toward becoming an LCSW, these diagnostic pairs that we're going to talk about today trip up people on the exam and in real world practice. So we're going to break them down with some clarity, hopefully give you some memory tools as well, and some real world examples of where you're going to see these things. First, let's look at the news. AI may soon aid in differential diagnosis for mental health. A recent article in the Psychiatric Times, December 2025, highlights advances in AI-powered clinician decision support systems. These tools use natural language processing and predictive analytics to flag possible misdiagnoses and offer differential suggestions based on intake data. Promising tools are being piloted in Europe and North America, with early results showing improved diagnostic accuracy for complex mood and personality disorders. This is one of those areas I'm really excited about with the tech that's rolling out. It's going to make our diagnoses, things around this, a little bit more accurate, and hopefully help people and not waste their time. It's frustrating to, and this is something that's happened to me like early on in my career, where I was going one way with a person and thoughtfully working through what I considered for a diagnosis, only to really realize that they were, after we worked for a while, that I should be going in a different direction. The specific example I'm thinking of, I think my supervisor actually pointed it out to me. And so you can imagine how frustrating that is for both clinician and patient. So something like this really gives me hope that we're going to be able to streamline the work that we do with individuals that much better, that there's going to be less trial and error, and just a little bit more insight for helping individuals. Next up, the ACA proposes diagnostic education expansion in graduate programs. So the American Counseling Association recently proposed new standards requiring more diagnostic training for in CACREP accredited programs. This includes a push for cross-comparison modules on disorders with overlapping criteria like PTSD versus GAD, general anxiety disorder, and ADHD, versus bipolar 2 disorder. The proposal stems from licensure data showing high failure rates in diagnoses related questions. So, this is one of the things we're going to go over today in the episode. But it's easy to get a lot of these diagnoses mixed up, and especially early on, especially on the test, there's just going to be some nuances to certain things that maybe length of time or onset of symptoms that are really going to differentiate one from the other, and it's going to come down to that one nuance that we need to understand, and it makes for a pretty high rate of just kind of messing these up and mixing things up. So the fact that the ACA is looking into just increasing education in this area, it should be really nice, really nice boom. So now on to the main topic today. So we are going to look at the 5 most confused diagnoses, and break them down clearly one by one, and give you some tools to help you discern between them. So first up, bipolar disorder versus borderline personality disorder. Key differences here. Bipolar involves episodic mood changes that last days to weeks. So think manic or hypomanic episodes. Borderline shifts moods within hours, driven by relationships, abandonment, fear, and identity issues. So right there, weeks versus days. Borderline, really significant mood shifts, versus episodes of mood changes with bipolar disorder. You can see like just that nuance there. And then with borderline personality disorder in particular, you have things that are driven by relationships with other people and fears of abandonment specifically. So really kind of helps you differentiate the two. It's not just, you can't just look at mood. And I think that's where a lot of people end up going with this, is they just look at like mood shifts, and it can be difficult to discern between the two. But a memory tool that you can use for this one: bipolar is a roller coaster with long hills, while borderline personality disorder is a pinball machine, fast, reactive, and relational. Next up, ADHD versus bipolar 2 disorder. People get this one confused because both include impulsivity, distractibility, and sleep issues. So first up, some key differences here. ADHD symptoms are chronic and lifelong, starting before age 12. Bipolar 2 is episodic, with distinct hypomanic periods lasting at least 4 days, and has major depressive episodes in there as well. So the memory tool for this one: ADHD is always there, bipolar just visits. Got it? I like that one. ADHD is always there, but bipolar just visits. Next, we have PTSD versus generalized anxiety disorder. This one is something that it can be really difficult to separate sometimes, because a lot of the symptoms, I think, that you see in both of them can just be so similar, right? So both include anxiety, restlessness, irritability, and sleep disturbances. Key differences here: PTSD is trauma-based and includes re-experiencing, avoidance, and hypervigilance. So you're looking for this within that initial intake. You're looking for people talking about, this history of trauma that they've had, moments where they relive the experiences that they have. With generalized anxiety disorder, it's chronic, excessive worry across multiple domains, not tied to a singular traumatic event. So with generalized anxiety, it's not necessarily based in a single or multiple events that happened in your past, but it's just this excessive worry across life. So memory tool for this one: GAD worries about everything. PTSD relives one thing. Next up, OCD versus OCPD. Why they get this one gets confused a lot simply just because of the name, right? OCD versus OCPD. People just mix up the names, and it's easy to do. So OCD is ego dystonic. People don't want the obsession slash compulsion, while OCPD is ego syntonic. People value their order, rules, and perfectionism. So, I remember talking about this one a little bit a couple months ago in an episode, talking about that OCD, or the personality disorders, and just how ingrained they are in the person's being. So people with OCPD, like they think they're right. Like they don't understand why the rest of the world is so unruly and out of order, and why people are so messy. Um, like they think they are right. OCD, they don't want to necessarily um, have these compulsions. All right, coming on to the last one in my list: schizophrenia versus schizoaffective disorder. Why people get this one confused? Both include psychotic symptoms. The differentiators between these two: schizophrenia, psychotic symptoms are primary. Mood symptoms may be present but are not dominant. Whereas schizoaffective, mood episodes, depression, mania are prominent and occur concurrently with psychotic symptoms. But there must also be at least 2 weeks of psychosis without mood disturbances. I know every single time when I was studying for my test, every single time I saw anything around weeks, days, months, it just caused me stress. It's just the idea that I have to memorize all these things, all these symptoms, all these things that go along with these different diagnoses, but then I also have to keep times straight. And to be fair, there are some questions like that on the test that ask around time. Luckily, if you can just get a couple of the main ones down, get a handful of them just down, you're going to be good. You're going to absolutely be good for the test. There's not going to be a ton of questions that are going to nail you down to really being able to discern between times. All right, let's look at some multiple choice questions. First up, a client reports persistent worry across many life domains and difficulty sleeping, but no trauma history. Which is the most likely diagnosis? Is it PTSD, panic disorder, generalized anxiety disorder, or adjustment disorder? Answer for this one's going to be generalized anxiety disorder. Chronic worry across domains fits for GAD, but no trauma was noted here. So you're going to go with that one. Next up, a 24-year-old describes organizing their closets by color and cannot stop thinking about their roommate's messiness. They find it distressing and want help. Diagnosis for this one is this going to be A, OCPD, B, OCD, C, GAD, or D, schizoid personality disorder? Answer for this one's going to be B. The key is distress and intrusive thoughts, right? So they don't want to be like this. Even though they had those like, oh, what's going on with my roommate? It's still like this is seen as an intrusive thought for them. Next, a 10-year-old struggles with attention, impulsivity, and poor school performance since kindergarten. Most likely, the diagnosis for this individual is A, ADHD, B, bipolar 1, C, adjustment disorder, or D, autism spectrum disorder. This one is going to be A, chronic early onset symptoms point to ADHD. Number 4. A client has major depressive episodes with psychotic features, but also has delusions during euthymic states. What is the best diagnosis? Is it A, MDD, B, bipolar disorder 1, C, schizoaffective disorder, or D, schizophrenia? Answer for this one is going to be C. Psychosis with and without mood symptoms equals schizoaffective disorder. Last question. A client with unstable relationships, intense anger, and chronic emptiness is most likely experiencing A, narcissistic personality disorder, B, borderline personality disorder, C, bipolar 2 disorder, or D, histrionic personality disorder. These are going to be core features of B, borderline personality disorder. How about we go over a vignette? So, Jamie is 27 years old, comes in reporting difficulty sleeping, intrusive thoughts about germs, and 2-hour nightly rituals of checking locks and washing hands. Jamie is distressed by these behaviors, but says they can't stop without fear of something bad will happen. They recently lost their job due to lateness caused by these routines. All right, folks, what are you thinking? So I'm leaning toward obsessive compulsive disorder, specifically um, considering like ego dystonic distress over compulsion and obsession. Um, there, if you think about some of the stuff that we talked about in the tools that we use to differentiate between OCD and OCPD, the ego dystonic people, they don't want these necessarily want these obsessive compulsive thoughts. And this individual, Jamie, um, it's talking about like how this is impacting his life in a negative way. It's he's talking about the distress um, by this. If he had OCPD, he wouldn't necessarily be all that distressed. A lot of the times, people with OCPD, similar to some of the other personality disorders, they don't understand what's wrong with the rest of the world. Not necessarily that they don't understand why they are having such a difficult time, why they're stressed out, why these things are impacting them in a negative way. People with OCPD are going to say, yeah, I can't believe my job wouldn't see how important this stuff is for me. Like, what's wrong with them? Not that they're coming in late because I have to do stuff, but what's wrong with them for faulting me for needing to do these things are important. So yeah, so OCD is going to be that initial diagnoses, differentials, OCPD, and then also generalized anxiety disorder. I'd probably put as a differential as well. Um, and like thinking about treatment around this, CBT is going to come up so many times on the test. It's what insurance companies prefer, and I think that is, it works. It's a really really great modality. I use CBT and a lot of the behavioral therapies within that realm, including REBT and DBT. All of these are just really, really great to address so many different issues. So maybe a little CBT with exposure and response prevention, ERP, and then referral to a psychiatrist. See if they might be able to help them out with something like an SSRI or something as well. I do a lot of work with psychiatrists. It's really great when you start your practice to befriend psychiatrist, and it really becomes a nice working relationship. They will get people that will come in just asking for medication, and they'll be able to refer them to you for therapy, and vice versa. People come in just for therapy, and because of the relationship that you have with the psychiatrist, you just refer right to them. It becomes a really, really nice way to network, and just have that um, these professionals in your life that can just seamlessly be referred to. All right, that is going to do it for the most part for this episode. I'm really hoping this cleared up some of these areas for you with these diagnoses. But keep practicing this stuff, keep comparing. I promise you that this will all make sense someday, and it will be just come to you so easily. But until then, keep studying and take care.